Hey, well, good afternoon, everybody. Good afternoon. It's good to see you guys. Hey, another good Wednesday at Lunch and Learn. Yeah, absolutely. And guess what? We're getting closer and closer to warm weather, right? I know we're all looking for that. Hey, look, today we've got a really good session going on. You know, we don't know oftentimes when to reach out to an occupational therapist. What's the benefits of it? When do I pick up that phone and call and say I need an occupational therapist? And so there's a lot of unknowns about that particular area. But today we've got someone here from the UW Hospital and Clinics that's going to give us all the 101 on everything about occupational therapists. So how about a good warm Fitchburg welcome for Kristin Campbell from UW Hospital.
Thank you, Janice, and thank you guys all for being here and for being so welcoming. I'm excited to come and to talk about occupational therapy. I'm very passionate about it. And even though I don't have another physical therapist with me today, because we work so closely together, in clinics, but particularly in the home health field, I wanted to also touch base on what they offer just to make sure that people are thriving at home. So we are talking about thriving at home from a therapy perspective. Just a little bit about myself. Again, my name is Kristin. I have over 5 years experience working in skilled nursing facilities and over 6 years working in home health. And I currently work as a home health occupational therapist with UW Healthcare Direct. Today, we've got a lot on our list for things to talk about. We'll be describing what occupational and physical therapies are, talking about fall prevention, energy conservation, staying active, edema management, which is that swelling, home modifications, adaptive equipment, durable medical equipment, referral to therapy services, and services offered by home health. And then questions. If you guys have questions, feel free, either shout, raise your hand as we're going, and I'll pause just to make sure if you guys have questions between, little items on our agenda, just so that we're not missing anything. So our description of occupational therapy, it is long and comprehensive. It's the therapeutic use of everyday life occupations with individuals or groups. The goal is to enhance or enable participation in roles and situations in various settings, such as home, school, workplace, and community. Occupational therapy is a science-driven, evidence-based profession that helps people of all ages live life to the fullest by promoting health and addressing illness, injury, or disability. Services provided include habilitation, rehabilitation, and health and wellness promotion. That is a lot. It's incredibly comprehensive. So I wanted to talk a little bit about, let's narrow that field down to what that might look like in someone's home. So we focus on activities of daily living. We call those ADLs. That's focusing on things like dressing, bathing, toileting, grooming, self-feeding. If someone has an injury, if someone isn't able to do those basic self-cares, what can we do in order to return them to doing it the way that they were, or how do we compensate for that? We focus on instrumental activities of daily living. We call those IADLs. That's things like meal preparation, laundry, housekeeping, medication management. We take a look at edema management. That's looking at swelling of the limbs, either if it's new swelling or chronic swelling, fall prevention, energy conservation training. We take a look at adaptive equipment training. Those are things like working with the long-handled reachers, sock aids, dressing sticks, button hooks. We take a look at durable medical equipment recommendations and training. So that's things like, recommending commodes or shower chairs, tub transfer benches, grab bars. We look at arm strengthening, range of motion training, fine motor coordination training, that's that dexterity, cognitive screens, cognitive exercises, and compensatory strategies if there are any cognitive deficits. And then what is physical therapy? I think we're probably all a little bit more familiar with physical therapy, but also just wanted to give that description again. It's treatment provided by a physical therapist or a physical therapy assistant that helps people improve their movement and physical function, manage pain and other chronic conditions, and recover from and prevent injury and chronic disease. So we're going to dive right into fall prevention. And so what are some of those fall risk factors? Things like weak muscles, poor balance, dizziness or lightheadedness, blackouts or loss of consciousness, foot problems, confusion or memory loss, vision and hearing impairments, medication use or misuse, change in behavior, bladder and bowel condition. So OT's role in fall prevention is taking a look at home safety modifications. So maybe recommending installing grab bars or possibly adding a ramp so someone can safely get in and out of the home. Adaptive equipment recommendations and training. So again, those things like reachers, sock aids, so someone may not have to bend over, putting them at risk for falls. Functional mobility during those day-to-day activities. And then also taking a look at cognitive and visual considerations. So using schedules, reminders, or labels for taking medication in order to avoid a medication error, or determining if there's optimal color contrast or lighting changes if someone has any visual changes or low vision that they have a hard time seeing, changes in floor surfaces, strips of paper along or tape at the edge of steps so someone can clearly see when that transition is happening, and energy conservation and fatigue management. And for PT, they work at improving strength and muscle function, enhancing balance and coordination, gait training, dual task training. So that's things like physical and cognitive tasks, thinking about walking as you are talking on the phone or trying to remember, the medication list or a recipe. Home safety and fall risk assessment. They'll talk about footwear and orthotic advice and assistive device training. So things like walkers and canes. So of course, we talk about fixing common hazards, things like increasing lights inside every room and hallways, keeping the floors free of clutter, adding grab bars in the bathroom, adding sturdy handrails on both sides of the stairs, putting in non-slip mats in the tub or shower, storing items within easy reach to avoid excessive bending or having to stand on your tiptoes, add night lights in every room, immediately cleaning spilled liquids, removing hazards from the floor and stairs, removing throw rugs, electrical cords, move sofas, chairs, and tables to allow enough space for walking, and never leaving anything on the stairs. And then moving and doing tasks with care, holding on to grab bars and handrails, avoid using chairs with wheels, don't climb on chairs or wobbly ladders, turning on lights when you're going into a dark room, installing a night light in the bathroom, bedroom, and hallway, and turning on lights if you get up in the middle of the night. Don't rush, slow down, pick up those feet. And talking about proper foot and positioning, also inspecting your feet to check for redness, cuts, sores, blisters, swelling, or loss of sensation. And also taking a look at footwear. Do you have good grip? Are you wearing closed-toed shoes? Are they lightweight? Does it offer good support? And is it something with a low heel? So before we dive into energy conservation, do you guys have any questions yet? No? All right. So talking about energy conservation, this is one of the things that occupational therapy will focus on a little bit more. How can we conserve that energy? So we talk about planning ahead. What does your day look like so that we can make sure that we don't have too much happening or too much planned in a day, depending on what you can handle. Pacing yourself throughout the day, taking rest breaks, or scheduling out your routine so that there's not too much clumped in the morning or too much just at night so that we don't overdo it. Prioritizing tasks for the day. Days that we have doctor appointments, it's very physically and cognitively taxing. So maybe we say that that's 50% of the energy for your day. How are we going to allot the rest of that 50% of the day? Using assistive devices to avoid, again, excessive bending or reaching. So things like reachers, sock aids, long-handled sponge brushes, just can help take away some of that taxing effort, minimizing that bending and reaching. Again, when we're not allowing those lungs to fully expand, when we're bending over, that limits our energy, fatigues us more quickly. Keeping most used items within easy reach, sliding heavy objects rather than lifting them, like a pot. If you're working on boiling water to make a meal, can we slide that pot over rather than lift it from one place to the next? Using rolling carts or walkers to transport items, like laundry baskets. Can we acquire rolling laundry baskets or place a basket on a rolling walker instead? Resting before you're tired. Keeping a daily routine checklist to reduce any mental fatigue. Certainly as the day goes on, that mental fatigue is much more prevalent. So if we have things, that checklist made out, we don't have to think about it later in the day. Staying hydrated to decrease that risk of fatigue. And then let's jump into staying active. So OT's role in exercise and maintaining functional activity, we assess mobility and function as it relates to daily activities. We'll create personalized exercise plans. So OT typically focuses a little bit more on the upper body strength and range of motion. So we might start exercises with resistive bands or hand weights, as well as taking a look at hand strengthening and hand coordination. So we might use resistive putty for hand and finger strengthening, and using items, household items like coins, pens, paper, medication bottles, just to work on coordination exercises, but in a very functional capacity. And for physical therapy, they assess muscle strength, balance, mobility, and endurance. They'll also create personalized exercise plans. They focus on legs, hips, core, back, and shoulder strength. They might initiate exercises using resistive bands, weights, body weight, or exercise machines, depending on your location, what you guys might have, or if you are in an outpatient clinic. They will modify positioning of the exercises, maybe starting while you're lying down and then working towards sitting up and then standing, depending on someone's capabilities. Determine pain management techniques or strategies. They also address cardiovascular conditioning, as well as exercise training to maintain bone density and prevent injury. So I won't go through all of this. The handouts that we have over here has all of these slides available. But I also wanted to provide what would like a general recommendation for activity for older adults look like that we might recommend. So talking about aerobic exercise, we typically recommend 3 to 5 days per week. And that's things like walking, swimming, cycling, dancing, chair aerobics. The classes that are offered here, fantastic. We want to aim for 150 minutes of that moderate intensity aerobic activity per week. Strength training, ideally 2 to 3 days per week. So that might look like those seated leg lifts, squats, which oftentimes we'll say, hold on to a countertop for support or a sturdy chair, wall push-ups, resistance band exercises, or light dumbbell exercises. Balance and stability exercises, also 2 to 3 days per week. That would be things like standing on one leg, heel to toe walks, working on Tai Chi, standing marching, or if you happen to have a balance board exercise. Flexibility and stretching. Daily would be fantastic just to make sure that we're maintaining that flexibility. We're not tightening up. Those joints aren't becoming misaligned. But at least 3 to 4 days per week. So seated or standing, the hamstring stretch, that's the back of that upper thigh. The quad stretch, that's the front of that upper thigh. A cat-cow stretch, that's for our back, that we're rounding it and curving it in. A chest opener stretch, and then neck and shoulder stretches. And then, of course, cognitive and social activities, doing things like puzzles, brain games, memory exercises, social dancing, group exercises. Again, so much of that is offered here, which is fantastic. Playing games, card games with friends or family. And then this is just a sample weekly exercise schedule. Everything that I just rambled on about, it can be very overwhelming when you think about how much time and energy that might be in a day. But taking a look at a sample calendar like this, it's between 40 to 45 minutes each day. So it's not that intense, but it just allows you to have something to look at and reference as you're thinking about how can I get this started for myself. Do you guys have any questions at this point? So she's saying that when she has been given exercise programs in the past, she'll stick with it for a couple of days, and then after that, she has a hard time sticking with it. So any recommendations for staying motivated with doing those exercises? I agree. That is a very common problem. I think some of us more experienced home health clinicians have started to realize that doing fewer exercises, giving you fewer rather than you having 20 exercises to do all at once, because that can feel so overwhelming and cumbersome. Trying to narrow that down to, 5 to 7 really good, important exercises so it doesn't take very long throughout the day. That at least helps people typically get started and stay with it so that they think, okay, I've timed myself. Sometimes I'll actually time someone doing it. So I can say, this has taken 8 minutes out of your day. We can make this happen. Let's find a good time for those 8 minutes. And then I also work with individuals, we'll have a blank calendar, and I might have the person write out, what does that routine look like each day? If you have a couple of OT exercises, a couple of PT, how can we spread that out so maybe you have no more than 2 or 3 exercises each day, rather than you having 5 or 6 every single day where it feels really cumbersome. Does that help at all? Maybe. A little bit? Okay. At least some ideas to try. And you have another question back there? Yeah.
And cheerleader in the pom-poms and go for it.
Love it. She said, get a cheerleader in pom-poms and go for it. I love it. Sometimes that internal motivation can be very difficult. And so sometimes it's also taking a look at what would be that reward for yourself. If you love going to see a movie, let's say you got through, a solid week of doing the exercises like you planned. All right, then, by that weekend, you've earned a movie. Or if there's another particular treat of yours, that's something that you look forward to doing. You can make that goal until it becomes a little bit more routine and feels less cumbersome and more just a day-to-day activity. That's a good question. Yeah. So what she said is on weekends, she'll listen to music that makes her feel like dancing. I love that. And she was asking if it's okay just on weekends. Here's what I'll say. Any activity, any movement is great. It's better than nothing. If you feel like you have more opportunity throughout the week, fantastic. If that doesn't work into your day-to-day routine, then that's okay too. Don't fault yourself for only doing it 2 days a week. Some days, arthritis kicks in. We don't feel like we can do quite as much. And so still figuring out how we can stay active, depending on what your body is willing to do. So general tips for seniors when exercising, really for any of us, starting slow. If you are newer to exercise, beginning with those shorter sessions, maybe just 10 to 15 minutes at a time, and then we work up from there. Warming up and cooling down, making sure that you're warming up your body. If you're going for a walk, maybe start with a slow pace and then work up towards being a little bit more brisk. And then gentle stretching afterwards to make sure that the body doesn't tighten up and that you're feeling pretty achy in the next couple of days. Hydrating, always important. Hydrate. Listen to your body. If you're starting to have any sharp and shooting pain, that's usually a sign that we need to calm it down. Yeah, we either need to stop doing what you have been doing, or if you're raising your arm and all of a sudden you realize it catches at a particular point, don't go quite as high, but still stay active without having that sharp shooting pain. All right, next we're going to talk a little bit about edema management. This is something I don't know if people frequently think about with therapy, but it can be a big part of our job. So edema management, that's talking about swelling of the limbs. OT and PT, we both address it. OT certainly addresses upper as well as lower body. I believe that some of the lymphedema, the certified lymphedema therapists, that can be either OT or PT. PTs also focus on upper body. But here are some of the diagnoses that individuals might have that you might see some of that swelling. So things like congestive heart failure, chronic kidney disease, liver failure, chronic venous insufficiency, lymphedema, cellulitis, rheumatoid arthritis, deep vein thrombosis, which is like blood clots, peripheral artery disease, and then surgery of the upper or lower limbs. So our job as therapists is to talk about positioning. We always recommend trying to elevate those limbs above the level of the heart. So gravity can do its job to try and bring that swelling out of those limbs, out of the hands, out of the feet. Skin care, we talk about trying to avoid skin breakdown and infection, focusing on hygiene management, moisturizing, avoiding pressure that can lead to too many sores. As far as OT, oftentimes it's us trying to problem solve. Well, someone can't reach their foot safely. How do we modify that task so that they can apply that moisture, so that they can thoroughly clean that limb? Talking about compression, education with use of compression garments, stockings, or wraps, teaching how and when to wear them to reduce swelling, and possibly fitting someone with a pneumatic compression device. That's something that's air pumped, that plugs in, goes over the legs, and just gently pumps that fluid out. Exercise and movement, helping individuals develop appropriate exercise routines that can also help to move that fluid out of the limbs, as well as maintaining the range of motion. And then sometimes we'll work on manual lymphatic drainage massage, and that's typically with a certified lymphedema therapist, someone who, they are certified specifically for that role, but to work on techniques to manually massage that fluid out of the limbs, and working on self-massage that someone can do at home just to make sure that they're trying to keep that swelling out of the limbs. And then I just have some pictures, arms, and then the next picture of legs of if you have experienced any swelling, if you have any concerns. This just kind of talks about the stages of lymphedema and what that might look like. So if you have concerns, absolutely bring it up to your doctor. And if you guys determine together that it's appropriate for a referral to therapy, they can recommend that you go either to an outpatient clinic, or if you're homebound, then a home health therapist can absolutely come out. Do you guys have any questions about the edema management before I move on? So she was saying that her husband had issues with swelling, and he would go into the clinic maybe once every other week or so. And a lot of it depends on certain diagnoses. So, if someone has heart failure and they can't tolerate like a pump per se, it depends on what someone's body can tolerate as far as trying to move that fluid. Sometimes if we move that fluid out of the legs, then the heart can't tolerate that. So we have to be careful about how quickly we do that. But typically, if someone is considered homebound, then our staff is able to come in. We can assess, we can work with the doctors to determine what someone's body can tolerate as far as moving that fluid, and work on, compression, the elevation, the exercises, and what is most appropriate for them and for their body. So it's fantastic, something, again, I don't think many of us think about as a therapy role, but I wanted to make sure that I touched base on this. So if that was something that you guys experienced, just to be mindful of that and bring that up to your doctor. Yeah. Okay, so she asked in the pictures why it only showed one limb swollen and not the other. That's a good question, and I meant to mention that. So while that can sometimes happen, depending on what the diagnosis is, what the person has going on, that only one limb is swollen, it doesn't necessarily have to be that way. Very frequently, it'll be both limbs are swollen, but just to varying degrees. The left leg might be more swollen than the right, but usually they both are. If someone had a mastectomy and they might have had lymph nodes removed, and just on one side, then typically you'll find just additional swelling just in one arm versus the other. If someone has a blood clot and that's the reason for the swelling, usually that blood clot is just in one leg, not all the time. But, in that instance, then it would just be a single leg that would be more swollen than the other. So that's a good question. Janice was asking, she said oftentimes swelling of the legs goes along with kidney disease. We do find that, a fair amount. I would say more frequently, what we have found lately is a correlation with congestive heart failure, a lot of swelling. So absolutely, kidney disease can lead to swelling because the kidneys aren't operating appropriately to filter that excess fluid out of the body. The fluid is looking for somewhere to go, and so it drains into that extra tissue. And so that is certainly one of the times that we would see swelling. In compression, elevation would be appropriate. But it very much depends on what that diagnosis is. Like I said, congestive heart failure is another very common one. Lymphedema is probably the one that we think of the most as far as more those extreme swelling, that stage 4 swelling that we would see. Does that answer your question somewhat? Okay. So Janice was asking if, we could talk a little bit more about those everyday compression socks and stockings. It can be quite a challenge to try and figure out what the right size is, even for us as therapists, trying to determine store brand stockings, what the most appropriate is. What I like is the stockings that on the label, it'll say how many millimeters of mercury of compression there are. And so that's where you'll see a range maybe of 10 to 20 mmHg. And that's what that means. That means how much pressure is being applied. The higher the numbers, the more pressure is applied to your legs. I would say if we are talking just about everyday compression stockings, that you don't have a particular diagnosis that a doctor or a therapist has told you that you need to have this certain level of compression, I would stick around the range of 15 millimeters of mercury of compression. So sometimes it'll look like on the label, it'll say 8 to 15. Sometimes it'll say 10 to 20. I would say those sizes would be appropriate, that there's still not so much compression that you are just battling to get them on, but they offer comfortable compression. They're easy enough to get on and off and fair for everyday use. Yes, that's perfect. So she's saying that she uses 15 to 20 millimeters of mercury compression, and that it's far easier to get on and off. Sometimes the higher level is appropriate depending on what someone has going on, and it's essential depending on what that diagnosis is. But for everyday use, for you to independently get that on and off, it is far more manageable, and it's still better than not wearing any compression at all. She's saying that buying compression stockings at Walgreens is much more expensive than just purchasing it through Amazon. I will say I probably recommend most people go through Amazon, partially for that and partially because, it's easier than guaranteeing that you can find a particular thing in the store. So I also use that frequently. Sizing sometimes, if it doesn't have a size guide, that can be the challenge. Even if I measure someone's legs, we line it up properly based on their shoe size, their calf circumference, their ankle circumference, and we'll get the stockings and they're still too tight. So that is the one wary thing, that we have not found necessarily a single reliable brand that always aligns with, what is recommended. Sometimes it's still that trial and error. But I think trying to figure out, if it says specifically what the compression level is, some of them don't even say what the compression level is. They just say that they are compression socks or stockings. I would at least try to target for a particular compression level. That's another great question. Janice said, is it dangerous to sleep with compression socks? No, it's not dangerous. But what can happen is that the compression socks, as we move in our sleep a little bit, they can fold down, roll over. That can create a tourniquet, and then that fluid and that blood flow has nowhere to go. And that can create a little bit more of an issue. It usually ends up creating more pooling of the fluid rather than actually being dangerous, but that can also lead to skin breakdown in that area. So for general use, we typically say, get up, go to the bathroom, and then immediately after that, put those compression stockings on, and then take them off before bed. For cases where someone has lymphedema and they might have wraps on all the time, or wound care changes because they have open wounds because of the swelling that they have, some of our compression garments called Circades or Sigvaris wraps that stay on a little bit better and they are less likely to roll down than just a stocking. Those sometimes we'll recommend 23 hours per day, or if it's actual compression wrap for wound care, it's usually changed 2 to 3 times per week. So those are the times that you would wear it at night. But just for everyday use, unless you have been told differently by a doctor or by a therapist or a nurse, I would take them off at night just so that they don't bunch up. So we'll talk a little bit about home modifications. These are some areas that OT and PT we absolutely focus on. In-home health is fantastic because we are going into someone's home. We see exactly how they're living, how they're moving, how they're walking. And so here are some home modification recommendations that we might have. So maybe changing out doorknobs to lever-style handles. If someone has decreased grip strength, arthritis of the hands, poor sensation of the hands that they have a hard time turning a knob, a lever-style handle might be an easy fix for that. Switching from a higher pile carpeting to low pile carpeting. If someone is using a wheelchair or a walker and they feel that it's getting stuck or they just can't independently get around with a wheelchair with higher pile carpeting, then we'll recommend considering low pile carpeting or more of a flooring surface instead. A no-step entry shower, that picture that we have, that lower right over there, that might be a recommendation that we would make. Certainly that is far more costly than some other recommendations, but that might be something that, based on the family, what their needs are, a long-term diagnosis for someone, that we may say, hey, this is a chronic disease. The progression will most likely be that they might end up needing a wheelchair, or they won't be able to step over a tub safely. So this would be the best option to go. Also talking about video doorbells, something like that just as easy if someone has a hard time getting to the door. So someone isn't getting up, rushing, putting themselves at risk for falls. If it's a video door that you can also speak out of, let's say a home health therapist is coming. We have quite a few patients that have the video doorbells that will ring. They'll see that it's us and they'll say, come on in, so that they don't have to get up, rush, or they're on a different level of the house. They can't get to the door. This is a safer option for them. Ramps, sometimes we'll talk about either modular ramps. This metal ramp is more of a modular ramp that can be taken away if this is just a temporary ramp. If someone has a surgery that the expectation is that they'll be able to use steps again, then maybe a modular ramp might be a recommendation. And then recommending maybe more of a permanent ramp, depending on what the person might need. So more of a wooden ramp, and what those recommendations would be, how, what the length of the ramp would have to be depending on the height of the steps, things like that. Stair lifts, that's something that sometimes we'll recommend if someone has difficulty getting in and out of the house. Sometimes having a stair lift is one of those things that allows people to stay in the home where they otherwise would not be able to, because they have to access stairs, and that's that one limiting factor that they can't safely do on their own. As well as elevator systems. I haven't had too many individuals who have needed that. I have certainly had a couple, but sometimes this elevator system, let's say, someone is wheelchair bound, and they can't even get up safely, transfer out of the wheelchair to get into a chairlift. something like this is great. Then they can roll directly into that wheelchair lift. It can take them up the steps, and now they can access their home where they otherwise would not have been able to. So I have probably about 20 slides talking about adaptive equipment and durable medical equipment. And there's some really good information in there. I did want to put, I'll show you the next slide. I kind of go through the rooms of the house and put names to the pictures. So if any of it looks like something that you or someone you know would benefit from, you can at least see what this looks like if you were to search, or if you were to ask one of the case managers at the senior center. You can say, hey, I think I need this. And so I want that to be a tool for you. But I also don't want to just blab on about adaptive equipment for 20 minutes. So I might skim by that to talk about some other reasons that we might need home health, and then we can come back to this. Does that sound okay with you guys? Okay. I'll skim by so you guys can take a look at some of the pictures. But a lot of bathroom equipment, grooming equipment, bedroom, dressing, more dressing, mobility aids, wheelchairs, transfer equipment, medication management tools, tools for arthritis, tools for low vision, things like magnifying glasses, of course. Magnifying glasses with lights can be, essential. Color contrast is huge, figuring out which colors you can see and cannot see together. Looking at audiobooks rather than print, trying to get that set up. Also taking a look at what large print works best for you and your vision. Some of the bump dots that we have up here, I've used those with individuals who they can't see the buttons on their microwave or on their stovetop anymore, to try and figure out, what that add 30-second button is on the microwave, or the start and stop, or locations for which burner correlates with, which button on there. Talking clock, they also have talking scales. So there's a lot more out there. Those are just a couple of the ideas. So electric can openers, built-up handles for eating and writing utensils. So, those foam handles that you can slide onto utensils might be an option. Otherwise, they actually make spoons, forks that have larger handles so that you don't have to buy that foam piece. Large TV remotes, if you have a difficult time pressing smaller buttons, they're universal remotes. Grip pads for opening bottles or jars. Key handle for turning keys. If you have a hard time holding on to those keys, that's that picture up there, so that you can use a couple of fingers to be able to manipulate that. Grip Solutions, or Dyson. Grip Solutions is a brand, as well as Dyson, that has a very strong grip. So the person with the tray down here, that it's not slipping, that is the Grip Solutions pad on there, so that you're not slipping. And then sometimes splints for the hand. This joint right here, the CMC joint, can be a tough one, that oftentimes if someone has arthritis, that joint falls out of place. It kind of dislocates. It's unstable. And so something like wearing, this a splint like this, just to provide that support of that joint so it doesn't dislocate every time you're trying to use that hand, can be beneficial. Honestly, again, Amazon is usually where I recommend people start. And that's where, I wanted to give names to some of these tools. So searching by these names. And so everything that I have on the side here, those are the names that if you were searching, that's what I would search for. That's what I wanted to try and give. Can just kind of go through some of that adaptive equipment, medication management tools, automatic pill dispensers, medication lists or charts. Right before this, I just color-coded bottles with a woman. We went through and adhesive dots of different color. We put those on tops of her bottles so she could visually see what was to be taken in the morning and at night, just to make that a little bit easier depending on, what she could handle, what she needed for organization. General safety, I will touch base on this quick. I have a couple of slides that talk about some different options for medical alert systems. So I think most of us are familiar with the Life Alert system. And this just kind of talks about some different name brands and then pros and cons, which I think can be beneficial. Life Alert is great, but it only works inside or near the home rather than out in the community. Mobile medical alert systems, ones that have GPS and cellular service. So it gives examples of the Medical Guardian, Mobile Help, Lively Mobile Plus. One of the cons is that it needs charging. It's usually a little bit more costly, but if there's that concern for falls and you are, very active in the community, this might be a nicer option for you. This talks a little bit about automatic fall detection. It can be a great tool. As far as a con, it says, there are occasionally false alarms. But this might be great if you or someone that has had issues with orthostatic hypotension, which is where your blood pressure drops very quickly and drastically when you change position. So, you're changing your sitting, you're standing up, and then your blood pressure drops, you lose consciousness, and you fall. You wouldn't be able to push a button. So it detects that fall. So it can be a great tool for those instances. Monitored safety alert systems connects to a 24/7 emergency response center, but it's typically a little bit more costly. And then they also have the non-monitored that any of those calls or responses would go to family members instead. And the only con would be that it might be a slower response, if your loved one is busy at the moment. But just some options to think about if you are considering a device at all. And then there's the wearable smart medical alert devices. Apple Watch has one with fall detection, which can be great if you already have something like a smartwatch or an Apple Watch. But you do have to be a little bit more comfortable with the technology in order to use that reliably. And then sometimes I've had people rely more just on their Alexa or Google Home. So let's say something were to happen, they know how to use their Alexa or Google Home and say, Alexa, call for help. And we've tested that together. So, they're not necessarily ready for a medical alert system, but they know that they have something in the house. And sometimes that allows family to feel a little bit better about it as well. Next, we're going to talk about therapy referrals. So home health versus outpatient. I want to be very clear about that, so that you guys know when it would be appropriate for home health or for outpatient. Home health, one of the biggest things that we have to say and justify in our documentation is that someone is homebound, whether it's just temporarily or long-term. So, that means difficulty leaving the home. If you're recovering from a major surgery or an injury, let's say you just had a joint replacement, you had a spinal fusion, you had a stroke, those would certainly be major events that you would be homebound. If you have severe mobility or balance issues, if your arthritis is very severe, if you aren't able to navigate the steps of your home safely, if you aren't able to safely get in and out of a vehicle, or you don't have that transportation available from a loved one, you can't reliably get, to a taxi, from a taxi to an outpatient clinic. Those are the times that home health is definitely most appropriate. And then chronic illness or condition that makes it difficult to travel. If someone has cancer, if someone has a respiratory illness, they're newly on oxygen, those are the times that you might be seeing us for home health. And not all the time, but frequently enough, someone will work with us for an extended period of time, and then we will send a referral to outpatient therapy when they're ready, because they're not quite done with their rehab, but they can safely and confidently get out of the house. So then outpatient therapy, if we're thinking about OT, PT, or speech therapy, are you able to travel to a therapy facility, either by yourself or if you have a family member, a reliable friend, or even a taxi service that you are able to get in and out if you require more intensive therapy? So let's say you had a knee replacement, we worked with you in home health, but now it's time that you work with more of the equipment, the leg bikes, some heavier exercise equipment. That would be the time for outpatient. Benefiting from a group therapy or more social setting, absolutely. If recovery is progressing and you're able to do more on your own, again, after a joint replacement or after someone has cardiac arrest, and maybe it's time to transition them from home to cardiac rehab or pulmonary rehab. Or if you require specialized therapy services, things like hand therapy, if you have a specific hand injury, if you had a surgery of the hand or the arm, a neurological therapy, so thinking more like stroke or spinal cord injury. Those are the times that outpatient, as soon as we can get you there, they have the equipment that is most beneficial for you. And so then I want to talk a little bit about comprehensively what home health can offer. Not every home health agency has occupational therapy, physical therapy, speech therapy, and nursing. We do at UW Healthcare Direct, and I'm grateful that we do. So that would just be the only caveat that, depending on which company you are working with and which therapies you might need, just making sure that they have everything that you need. So again, home health OT, we take a look at rehabilitation after surgery or an injury, adaptive techniques, motor skill development, both gross, those bigger motor movements, and fine motor movements, the dexterity, coordination, things like handwriting, eating, cutting up food, managing coins. We will do home safety assessments, go throughout your home, what that daily activity looks like, that routine. What can we help with? What can we make any easier? What can we modify? As well as cognitive support. If you're having a hard time managing medications, remembering to take them on time, anything cognitively as far as being able to organize, we can assist with that, break down that task. What can we do that works for you? Home health physical therapy, that's the post-surgery or injury recovery, looking at pain management, strengthening and conditioning, balance and fall prevention, improvement in mobility and gait. And then home health speech therapy, so speech and language disorders. So if someone had a stroke, if someone has Parkinson's, some of those more neurological disorders that they aren't able to speak the way that they used to, working on exercises with that. Swallowing disorders, also called dysphagia, if someone's having difficulty swallowing, leading more to aspiration pneumonia. They're getting sick all the time, looking at exercises to help strengthen that swallow, but then also modifying the type of food or drink that they're having so that they can safely eat without that food going down, down into their lungs. Cognitive and communication disorders. Again, thinking maybe after a stroke or a brain injury that someone might need a little bit more help, thinking of word finding, putting those cognitive connections back together. Voice disorders, if someone has hoarseness or, again, with Parkinson's, usually the voice, it starts to get a lot softer, so working on how we can strengthen that, and social communication. And then our home health nursing, they take a look at medication management. They help organize medications, discuss side effects. They'll work on wound care if someone has an open wound, as well as ostomy care if someone has a new ostomy. Chronic disease management, post-surgical care, vitals, and then patient and family education. You have a question? Sure. So social communication, that would be, I would say more like if someone has autism or dementia, and they're trying to work on how we can figure out how to communicate with others. Dementia would be a situation that maybe an individual has forgotten how they can properly communicate with one another. Also taking a look at like developmental disabilities and, autism, some of the diagnoses that might be for more of a younger population, but taking a look at social skills with that. Cognitive communication disorders. So again, that would be more like if we are thinking about any neurological deficits. So dementia, stroke, things that someone isn't able to properly organize their thoughts anymore, word finding, word retrieval, that they can work on exercises or compensatory strategies in order for someone to be able to communicate that way. Some of our speech therapists have been fantastic. One of our speech therapists worked with an individual who, everyone thought that he couldn't speak for several years, sadly, and she worked on a form of communication that, she would have him tap several times for yes or no, and he was understanding things. No one knew just how to tap into what his brain could comprehend. So they can be fantastic as far as trying to problem solve those different areas. But I wanted to give some more examples. When you guys are thinking, hey, am I appropriate for therapy? Truly, we see a little bit of everything. So generalized weakness, frequent falls, acute exacerbation of congestive heart failure, knee, hip, or shoulder replacement, urinary tract infection, spinal surgery, dementia, COPD exacerbation, arthritis, Parkinson's, pneumonia, cellulitis, lymphedema, stroke, fractures, pain, difficulty walking, contractures of the hand, low vision, bladder incontinence, unsteadiness on feet, pressure ulcers, osteoporosis, chronic kidney disease, amputation, mastectomy. So I just wanted to give kind of this list that you guys can see that even if you don't have necessarily a diagnosis of, a joint replacement or a particular fracture or a particular pain, that doesn't mean that we don't see the whole body and that we still treat a little bit of everything. You may not think that OT and PT would be crucial for someone that has a urinary tract infection, but we see so much of that because it weakens the body. It usually causes confusion, puts people at higher risk for falls. We take a look at, are they safely taking their medications? Is that part of it? How can we improve their hydration because they're clearly not hydrating well enough? Or, what could be the source of this? How do we educate them on determining what those signs and symptoms are? And so all of that falls under this umbrella of therapy services that may not be quite as, it may not stand out to you as much. So when you're thinking about, is this something that I could benefit from? There's a lot that we can offer. Do you guys have any questions? Cellulitis. So that's an infection of the skin cells. So oftentimes, if there's like a small wound on the leg, honestly, even just a crack in the skin, which is why we really encourage moisturizing, bacteria gets in there. It becomes this red swollen area. You need antibiotics, but it causes a lot of swelling as well. Yeah. She's asking if we find memory loss, more prevalent in specific diseases. Certainly the diagnosis of dementia and Alzheimer's is one of the big areas. I would say, as you and I were talking earlier as well, depression is certainly another area. There can be significant memory loss just because of the way that the way that depression works, that it starts to shut down areas of the brain as well. And so that creates memory loss, but it may not present itself on an MRI to look like you have actual dementia. Parkinson's is another area. Parkinson's and Alzheimer's are very closely linked. So if someone has Parkinson's, then not all the time, but quite a bit, we'll find that there may be some of that memory loss as well. Other than that, so urinary tract infections, as far as more of that acute memory loss, not a long-term thing, but that's certainly something that we'll see, that someone is confused or forgetful if they have an injury like that. I can't say that I've worked with as many individuals that have lupus, so I'm not as certain about lupus and having memory loss, if there's a correlation with that. Well, I'll just be over here if you guys have any questions.
How about another big round of applause for Kristin? That's a lot of good information. And again, like she said, that the copy of the slides are over here on the counter and exercise documents. Please take those with you. And I hope you learned a lot today. So have a good afternoon.